This graph represents the cardiac pressure volume loop. The x-axis represents ventricular volume and the y-axis represents ventricular pressure. As blood flows from the left atrium into the left ventricle during diastole, ventricular volume increases with a relatively small rise in pressure. This filling phase follows the end-diastolic pressure-volume relationship, or EDPVR, which reflects the passive mechanical properties of the ventricle. The maximum volume reached at the end of filling is called the end-diastolic volume, or EDV. EDV is a primary determinant of preload, which refers to the initial stretch of myocardial fibers before contraction. An increase in end-diastolic volume shifts the operating point towards the right along the filling curve. Conditions that increase preload include volume infusion, pregnancy, exercise, and volume overload states such as certain forms of heart failure. A decrease in end-diastolic volume shifts the operating point towards the left. Conditions that reduce preload include dehydration, hemorrhage, and venodilation. As blood enters the ventricle, the chamber expands to accommodate the incoming volume, stretching myocardial fibers in the ventricular wall. The ventricular wall resists the stretch, generating passive tension that produces pressure within the ventricular cavity. The pressure-volume relationship during filling reflects ventricular compliance, defined as the change in volume produced by a given change in pressure. A highly compliant ventricle accommodates large increases in volume with minimal increases in pressure. A less compliant or stiffer ventricle shows rapid pressure increases even with small increases in volume. On a pressure-volume graph, compliance is not the slope itself, but is inversely related to the slope of the filling curve. A steeper filling curve indicates reduced compliance, whereas a flatter curve indicates greater compliance. Reduced compliance is seen in conditions such as concentric left ventricular hypertrophy, restrictive cardiomyopathy, myocardial ischemia, and aging. Increased compliance may occur in eccentric hypertrophy, such as dilated cardiomyopathy, and can also be present physiologically in endurance-trained athletes. Once ventricular contraction begins, both the mitral and aortic valves are closed. Because no blood enters or leaves the ventricle, volume remains constant, while pressure rises rapidly due to active myocardial contraction. This phase is known as isovolumetric contraction. The pressure the ventricle must overcome to open the aortic valve is referred to as afterload. Afterload reflects the resistance imposed by the arterial system and is influenced primarily by aortic pressure and systemic vascular resistance. The ventricle must generate sufficient pressure to overcome this load before ejection can begin. Once ventricular pressure exceeds aortic pressure, the aortic valve opens and ventricular ejection begins. During ejection, myocardial fibers shorten, ventricular volume decreases, and blood is expelled into the aorta. The volume of blood ejected with each beat is called the stroke volume. The volume remaining in the ventricle at the end of contraction is the end systolic volume, or ESV. The proportion of EDV ejected during systole is the ejection fraction, which normally ranges from approximately 55% to 70%. If end systolic pressure volume points obtained under different loading conditions are connected, they form the end systolic pressure volume relationship, or ESPVR. The slope of the ESPVR reflects ventricular contractility, the intrinsic ability of the myocardium to generate force independent of preload and afterload. A steeper ESPVR indicates increased contractility, while a flatter ESPVR indicates reduced contractility. Increased contractility occurs with sympathetic stimulation, such as during exercise, or with inotropic agents like dobutamine. Reduced contractility occurs in conditions such as systolic heart failure, myocardial ischemia, severe acidosis, and with negative inotropic medications such as beta blockers. Changes in afterload shift the end systolic operating point along the same ESPVR, provided contractility remains constant. Increased afterload moves the end systolic point upward and towards higher pressures, as seen in hypertension, aortic stenosis, and systemic vasoconstriction. Reduced afterload moves the point downward, as seen with vasodilation, sepsis, and vasodilator therapy, including ACE inhibitors. As after ejection, the ventricle begins to relax. Both valves are closed, so volume remains constant while pressure falls rapidly. This phase is known as isovolumetric relaxation. Together, the four phases, ventricular filling, isovolumetric contraction, ejection, and isovolumetric relaxation, form the cardiac pressure volume loop. The area enclosed by the loop represents stroke work, the mechanical work performed by the ventricle during each heartbeat. The pressure volume loop integrates ventricular mechanics, myocardial physiology, and cardiovascular hemodynamics into a single comprehensive framework. If you found this video helpful, don't forget to like and subscribe.